Good morning. My name is Jeanne Palmer. I am an associate professor of medicine at Mayo Clinic in Arizona. Today I will be talking about the role of JAK inhibitors surrounding allogeneic stem cell transplant for myelofibrosis. As many people in this audience will know, allogeneic stem cell transplant is a very good option for treatment for patients with myelofibrosis. It is the only option that is available at the present time that provides a curative treatment. However, it is appropriate to it is best to appropriately select patients for allogeneic stem cell transplant to make sure that it's the appropriate timing, the appropriate patient to allow for the best outcomes. When we start to look at the selection of patients as well as the timing of patients, there's a lot of things to take into consideration. The first thing to take into consideration is the risk profile of the patient. So when you look at the risk for for myelofibrosis, there's several different layers of risk we evaluate. The first one is looking at the DIPSS score, or the Dynamic International Prognostic Scoring System. This takes into account factors like anemia, white blood cell count, blast percentage, constitutional symptoms, and age. We can even enhance that further by doing things, looking at transfusion dependence, platelet counts, and cytogenetics, which would be available on bone marrow biopsy. The next thing we look at when we evaluate risk is we look at the driver mutations. So we look at things like calreticulin mutation, which is a good prognosis versus having no driver mutation, so no JAK2, MPL, or calreticulin, which conveys a worse prognosis. Finally, we can look at things like next generation sequencing. What this does is provides an overview of the molecular landscape of the patient's disease, which can be very helpful in determining what will happen to them moving forward. So for example, if somebody has a high risk mutation such as ASXL1, U2AF4, SRSF2, IDH1 or 2, or EZH2, these can all convey a higher risk of transformation to acute leukemia and a shortened overall survival. So when deciding on transplanting a patient, these are really critical pieces of information to have because they will help us determine within certain DIPSS scoring risks what the risk of the patient is. And there are actually current scoring systems that will take into account not only some of these clinical risk factors such as anemia, age, et cetera, but also take into account these molecular risk factors, which are very, very important when discussing with the patient, timing about transplantation, et cetera. Generally, we do transplant for patients with myelofibrosis who have DIPSS intermediate 2 risk. So when doing the scoring system out, this would be 3 to 4 points on the accumulated through that DIPSS risk scoring system. In the setting of somebody who has high risk molecular mutations, we often consider doing it at intermediate 1 risk, which would be a little earlier than standardly done, but it is important to consider that in patients who have high risk molecular mutations, as we know their disease tends to progress faster and there is a higher risk of transformation to acute leukemia, which we don't want to have happen because it will certainly worsen the transplant outcomes. One recommendation as a transplanter that I have is that patients get seen earlier than you would want to transplant them for myelofibrosis. The process of getting everything set up for a transplant, as well as the mental process of sort of coming to terms with what a transplant involves, is really important to start early on in the disease process. So if somebody has low risk or intermediate 1 risk, and you say, well, this person's not quite ready for transplant based on all the evidence that's out there, it's still a good time for them to see a transplant physician because we can start the conversation about what are the different risks that indicate a transplant is appropriate, as well as determining what clinical factors should really prompt us to move forward sooner rather than later. I see transplant and myelofibrosis as a shared decision-making process. So it is something that as a transplant physician, I feel it's very important to have ongoing discussions with the patient to really clarify what are these risk factors, what does your survival look like with said risk factors, and when is the appropriate time to do a transplant for each patient. So that is something that is very important when thinking about bone marrow transplant for myelofibrosis. The next question is, what do you do with the JAK inhibitors surrounding the time of allogeneic stem cell transplant? And this is something that has been much more of interest in the last 5 to 7 years since we've really had JAK inhibitors well entrenched in clinical practice. And this is something that there's not a perfect answer for. So for example, we know that the benefit of JAK inhibitors is that they will reduce the size of the spleen. They will reduce the symptom burden. And in patients who we do achieve shrinkage of the spleen and symptom burden reduction, we know that they can actually improve overall survival. However, in the setting, what we also know from the original COMFORT studies that were done is that the median time of response is approximately 3 years. So when you start somebody on a JAK inhibitor like ruxolitinib, they may have a great response up front, but if we look at the population that was treated in the COMFORT studies, we know that response will last about 3 years. Of course, there's always outliers who will have a longer time of response versus outliers that will have a shorter time of response. So when starting a JAK inhibitor, that's something we have to keep in mind. We also know that once somebody quits responding to a JAK inhibitor, loses their response, they start to develop worsening blood counts, their spleen starts to become more enlarged. We know that at that point, the disease has clonally evolved. We will often see acquisition of newer high-risk mutations, such as the ASXL1. And these mutations will convey a worse survival moving forward. So we know that the median survival after failure of JAK inhibitors is about 14 months, at least based on some studies. However, that being said, there's also evidence that transplant can be a good salvage strategy. Knowing that, however, I still prefer that when a patient has had a nice response to a ruxolitinib or a JAK inhibitor of any sort, that is the time frame where you really want to start thinking of transplant. Now, whether you take them right after they've had that response to the JAK inhibitor or whether you wait till you start to see signs that they are losing that response is something that's not completely clear, and definitely something that is an ongoing discussion with the patient as they are being treated with the JAK inhibitor. Another question that comes up during all of this is, well, what do you do? Because now there's fedratinib, which is approved, which is another JAK inhibitor that can be used in the first or second line setting. We know that in patients who have progressed through ruxolitinib, fedratinib provides about a 30% chance of achieving a significant spleen or symptom response. Do we wait until somebody has progressed through both of the ruxolitinib as well as the fedratinib? My thought is generally no, because we do know based on some of that original data, progression through ruxolitinib does indicate a sign of both clonal evolution as well as a shortened survival, that it's probably good if the person is going to proceed with transplant, that's the time that they do it in. After all, it is only a 30% chance that they will respond appropriately to fedratinib in the setting of having progression through ruxolitinib. That being said, all patients are different. So there may be circumstances where somebody says, I really don't think I'm ready for transplant, but then they just have to understand the risk that they may lose their window of opportunity for transplantation. Another question that comes up with JAK inhibitors is second-line JAK inhibitors or third-line JAK inhibitors, as it were. So we are currently in clinical study are 2 other JAK inhibitors that are being looked at in the setting of myelofibrosis. One of them is called momelotinib. Momelotinib is a JAK2 inhibitor that is better for patients who have anemia. Therefore, that we have found that in patients who have anemia, that there's a higher rate of transfusion independence that's achieved. And they seem to tolerate or are able to achieve better JAK inhibition with momelotinib because of the fact that it works better with anemia patients. The second JAK inhibitor that is also in phase 3 studies is a drug called pacritinib. Pacritinib is another JAK2 inhibitor that really seems to have its niche in treating patients who have thrombocytopenia. So, for example, if we look at ruxolitinib or JAKi, patients who have platelets of less than 100 are generally not recommended to go on therapy. Now, a lot of us do treat patients who have lower platelet numbers with ruxolitinib with good success, but it does limit how much JAK inhibitor, what the dosage we can use of said JAK inhibitor, because it will we're limited by the fact that the platelets will go down. And the same thing applies to fedratinib. Fedratinib's cutoff for starting to start patients on fedratinib. The platelet cutoff is usually 50, and we do have to dose adjust based on the platelet count as well. And in this setting, so for patients who have platelets of less than 50, we're really limited with what our options are. And pacritinib is one of those drugs that may be able to be used in the setting of thrombocytopenia. All that being said, I still think that when we look at the rate of response, even in these JAK inhibitors that are more tailored towards patients who have anemia or thrombocytopenia, we're looking at response rates between 30 to 40% in patients who have failed ruxolitinib. Therefore, even though these are good options. And I think that the role moving forward is going to be very clear, even in the upfront setting in patients with anemia or thrombocytopenia, respectively. I still would not choose to go through 2 JAK inhibitors prior to moving forward with transplant, just because we know, as I said before, the data progressing on ruxolitinib demonstrates that patients have a shortened survival and clonal evolution. And more importantly, is that the second line JAK inhibitors or any JAK inhibition used in the second line is likely to only have a 30 to 40% response. We do know in terms of what's the timing like, how do we navigate the JAK inhibitor peri-transplant? So there are several studies now, both prospective as well as retrospective, that show a benefit to patients who have undergone some JAK inhibition prior to moving forward with transplant, presumably because they have a decreased spleen size, they have a lower cytokine profile, so they don't have nearly as much inflammation going on as a result of the JAK inhibitor. And therefore, there's even one prospective study that shows about a 90% one-year survival in patients who are pre-treated for at least 2 months with JAK inhibition prior to moving forward with transplant. This is something that I think we all should be considering when we do put somebody on a JAK inhibitor. Now, whether, of course, we wait till they first respond to the JAK inhibitor and bring them to transplant versus whether we give them some time on JAK inhibition prior to moving forward with transplant is a very individualized decision, and we don't have a clear answer for that in the literature. Now, one of the recent strategies that's been employed by a couple different groups is actually peri-transplant JAK inhibition. And so there have been a couple of groups who have presented data on this or published on this, where they use JAK inhibitors not just up to the point of transplant, as the current strategies usually decrease or taper the JAK inhibitor just prior to the time of starting conditioning. However, some of these are going through the time of transplant and up till either count recovery or day 30 following transplant. There was initially concerns that this may worsen the infection risk, because we do know that JAK inhibition does suppress the immune system, or that it may impact engraftment. However, in a couple of small studies, this has not been borne out, and we do see that there's very reasonable rates of engraftment. There's no increased rates of infection, and then there's also no increased rates of graft versus host disease. I think moving forward, knowing the benefits we're getting from JAK inhibitors in the setting of steroid refractory graft versus host disease, our next step will hopefully be looking at potentially even using JAK inhibition as a means of GVHD prevention in some of these patients, especially with myelofibrosis. However, these studies are yet to be done, and we do not have data on that so far. A final question that comes up is one of the most exciting things that's happened in the last 2 years in the setting of myelofibrosis is clinical trials that are using novel agents in addition to JAK inhibition to treat myelofibrosis. So there's things like CPI-0160, which is a drug produced by Constellation and is a BET inhibitor or a bromodomain inhibitor. There is navitoclax, which is a drug that is also being studied in the setting of both upfront as well as people who progress through JAK inhibition. And this is a medicine that is a BCL inhibitor, which can provide different pathway inhibition that may not only just reduce the symptom burden and reduce the spleen size, but it may also help change the course of the disease. And one of the things we're seeing with some of these newer agents is that we're not only just seeing reduction in spleen size and symptom burden, which has historically been our response criteria used. However, we are also seeing a decrease in the fibrosis in the bone marrow, as well as a decrease in the clonal burden. So for example, we'll see reduction in the JAK2 mutational burden. We'll see reduction in ASXL1 mutational burden. And many of these agents not only work just with, work with patients who have standard risk, but even some of these high-risk patients are seeing a benefit from these novel agents. So one of the questions that comes up with a lot of patients is, well, geez, if these new agents may potentially change my disease course, what does that mean for transplant? For right now, I do not think that means we do anything different with transplant. I think that these agents provide a fantastic option for patients who are not eligible for transplant. And I think moving forward that these new agents could potentially even make somebody a better candidate for transplant when used prior to transplant or after transplant to prevent disease relapse, especially in those who have high-risk disease features. However, that being said, these studies are yet to be done, and I would not defer on transplant based on the ability to have one of these study agents being used. I am hopeful, as I said, that these drugs will enhance our transplant outcomes once they become more clinically readily available and even provide relapse prevention strategies. But for right now, I primarily would stick to somebody who has, once they've been on a JAK inhibitor and have decided to move forward with transplant, to go forward with transplant at that point and not employ a number of other different therapies, unless the patient really would prefer that way. However, just as I said with the second line JAK inhibitors, with these other new agents that are being employed, that still does potentially convey a risk that the patient will progress to the point where transplant's not a clinically relevant option at that point. I would like to leave with a couple of other bits of data that have come out that I think are really, really encouraging, as both for patients who have myelofibrosis, as well as clinicians who are trying to decide, do I really want to refer my patient for transplant, knowing how much people have struggled with in the past. And I think there's a few things that come out of it. First of all, our outcomes are better now than they used to be. So if you look at outcomes from the early 2000s, the early 2010s, and even in the last 5 to 6 years, we have gotten better outcomes, better overall survival with transplant. I think the reason being is people recognize this as a good treatment modality and are referring patients earlier to transplant. Where we find the worst outcomes are in patients who have very advanced progressive disease or have had blast crisis or progression to AML. So by catching patients earlier, by getting them in the whole involved in transplant earlier, I think we are providing much improved outcomes. We also have some great data that was published by the European group, which demonstrates if you take patients who've survived to 2 years out from transplant, so patients who are 2 years out after their transplant have no evidence of disease relapse, that their long-term survival is very good, upwards of 80%. And especially in patients who are younger, they have very good long-term survivals achieved by doing transplant. And so even though these survivals are not that would be seen in somebody who is never sick, we can certainly see long-term survivals that are quite meaningful to patients and are definitely provide a light at the end of the tunnel that people can achieve good responses and potentially even cure from doing a transplant, even though it does come at a little bit of a cost with regards to morbidity and graft versus host disease. So I think to summarize of what we know about JAK inhibitors, about transplant, about some of the newer agents coming out for myelofibrosis, is number one, transplant still remains the only curative option for myelofibrosis. The timing of transplant is very important and still remains to be around DIPSS intermediate 2, although in certain cases, DIPSS intermediate 1 is an appropriate time to consider transplant, especially in the setting of high-risk mutations. Referring patients to transplant earlier is better. It allows for a very good overview of the different risks involved, as well as ongoing discussion with the patient that helps them become acclimated to the idea of transplant. It also helps for a determination of appropriate use of JAK inhibition surrounding the time of transplantation. I think to summarize what we know about JAK inhibitors prior to transplant, that it is safe. There's even some data suggesting that peri-transplant JAK inhibition may be helpful in the setting of bone marrow transplant, although that data is still evolving and more to be learned about that. But we do know that providing some type of JAK inhibition prior to transplants in patients who are appropriate for JAK inhibition may provide a benefit after transplantation. And finally, we do know that these long-term outcomes are possible, that we have now some good long-term data that transplant can be a curative option that can provide life expectancy for patients with myelofibrosis and should certainly be considered in the appropriate patient population.